Hello and welcome to the October meeting for the Rural HPV Vaccination Learning Community on behalf of the American Cancer Society and the American Cancer Society's National HPV Vaccination Roundtable. I want to thank you for taking time out of your busy schedules to join us today, whether that's live or via recording in the future. We will be offering live CME and CNE credits for today's session. This session will spotlight a key opportunity in HPV cancer prevention, starting vaccination at age 9. Early vaccination offers stronger protection and more time to complete the series, an especially important strategy when we're thinking about rural communities. So we'll explore the why behind age 9 and how it can support increased HPV vaccination uptake. I do want to note this program is supported by a grant from the Centers for Disease Control and Prevention of the U.S. Department of Health and Human Services. If you want to go to the next slide. So I'm Ashley Locke, HPV Disparities Program Manager. I have the pleasure of talking with you first, and I'm joined by several American Cancer Society colleagues today who are helping to make this session a big success. So thank you. Next slide. So now that it's officially fall, which is my favorite season, I wanted to ask if you could share in the chat your name, your organization, and how your team or organization is leveraging flu vaccine season as an opportunity to promote HPV vaccination. And I'm going to circle back around to that in just a minute. If you want to go to the next slide. So for today's session, we'll hear from a cervical cancer survivor, Sarah Johnny, in just a minute, followed by Dr. Heather Brandt from St. Jude Children's Research Hospital. We're going to end the session with a Q&A, and we have a ton of resources to share with you. I do want to share just a couple of quick reminders. So all of our rural HPV vaccination learning community sessions are recorded and posted to a public-facing website. So please turn off your camera if you don't want your image recorded. This session is certified for live CME and CNE credits. We've added a link to the chat detailing out CME information for today's session. I just want to note none of the planners or speakers for today's session have any disclosures to share, and we ask that all of our participants stay muted until our Q&A. However, the Zoom chat will be open for questions and support, so please utilize it. Next slide. All right, so for today's session, we will be focused on the following learning objective, describing how to increase on-time HPV vaccination rates in rural communities. Next slide. So before we turn it over to Sarah, I do want to do a quick check-in and have participants share if your organization is regularly recommending the HPV vaccine at 9, if the HPV vaccine is declined by a patient or a parent, are you recommending it again in the future, and any barriers you may be experiencing around HPV vaccine at 9. So we're going to go ahead and give it a minute. Please go ahead and feel free to share via the poll. I'm also going to take a look at the chat and just see if we had any great ideas come through about HPV vaccine and flu vaccine together. So Dr. Brandt shared that although we do not focus on flu vaccine through our program efforts, she's definitely interested in hearing all of the great things you have to share. Andrea said that they're not currently focusing on flu season for HPV vax, but it's a really great idea. So please feel free to share if you are pairing up flu vaccine and HPV vaccine. Taylor shared she recommends flu and HPV vaccination, though don't stock vaccines at their work site. So making those recommendations together. Cassandra shared bringing HPV with us to all flu vaccine clinics. We send all our kiddos K through 12 letters if they are due for any vaccinations. This includes HPV. We go to the schools once per month and go to community clinics in 2 locations, 1 time per month. We look everyone up at the times for community clinics if they're due for any vaccinations, including HPV. So that's really great to hear, Cassandra. I don't know if you'd be willing to email us a letter or a copy of your letter that we could share with others. Penny shared that she reviews all vaccines due or overdue at appointments, including vaccine-only appointments or walk-in community clinics. So that's really great to see as well. Perfect. And for those that are just joining, we're quickly doing a poll, and then we're reviewing if anyone is doing anything fun around pairing flu vaccines with HPV vaccines. So Tracy shared that their MAs scrub all 9-year-olds who are coming in for an appointment and have the VIS sheets ready to give to the parents who are rooming the patients. Then the provider talks to the parents. That's really great to see. And then Penny shared that the Wisconsin Immunization Registry just updated the state program to prompt for HPV vaccine at 9. So that's, Penny, that's really wonderful to see and hear. So thank you for sharing. Looks like we've had 52% participate in the poll. I'll give it just a couple more seconds and then we will move along. All right, we can go and end the poll. Perfect. And you can go ahead and share them out. Looks like almost, so 93% of the organizations that are, or individuals that are joining in organizations are regularly recommending the HPV vaccine at age 9. So that's really great to see. And that 71% are recommending the HPV vaccine again at future visits if it is declined by a patient or a parent. So thank you all for participating in the poll. And we can go to the next slide. Perfect. Well, I am excited to introduce Sarah Johnny, Survivor Ambassador located in Virginia. We've included Sarah's full bio in the chat, so you can read that and connect with her on LinkedIn. But Sarah, the floor is now yours.
Okay, well, thank you. Hi, everyone. I'm going to try to do this as much on time as possible. My name is Sarah Johnny. I am just like Ashley said, cervical cancer patient and a survivor advocate. And I'll kind of get into that a little bit more. But I appreciate you guys listening to my story and just allowing me to just share what I can to help others share or help others get help that they need. So I'm currently 37. I had to think about it. I'm 37 and I work as a physician assistant. I'm in urology and I love it. And I was doing all of that until 2019. I was diagnosed at age 31. Oh, good. Next slide. Sorry. Diagnosed with stage 1A1 cervical cancer. Really, really small. Never missed my pap smears. I never missed a well woman exam, and I actually never uh, actually got the first Gardasil in vaccination. So I thought I was like good and covered, but it still came. So next slide, please. With the stage 1A1, it's the lowest one. It was small. I was like, okay, what do we got to do? So this has been kind of the progression of my journey so far, and it continues. I have done screening. I got the vaccination, like I said. I did have an HPV positive diagnosis in my early 20s, did go away and clear, and I had normal PAPs after that. I again came back abnormal in 2019, prompted the colposcopy, prompted a leap, which found the small tumor. My husband and I had just recently gotten married a year and a half ago. Didn't have any children. My gynoc wanted to have a hysterectomy. I didn't want to. I asked for a cone. So she did the cone. Margins were negative. All right, we're good. We're clear. This is just something that we came through. So then we get pregnant. It was amazing. Not all cervical cancer patients are able to have children, and infertility is one of the hardest and most frustrating and emotional things that we deal with. And no matter where you are in this. So I had my beautiful daughter and continue with my pap smears every 4 months. Next one showed abnormal again. and we did a biopsy, and lo and behold, 9 months later, I had more, my cancer had come back. So next slide, please. That led to a hysterectomy in 2022. And I was not ready for this because we wanted more children, but cancer didn't care. Cancer took that away. So 2022, I had a hysterectomy. I was restaged from 1A1 to 3C1 because it had spread to a lymph node. And there was actually positive margins because it was such a disaster. It was just a really bad surgery. Not surgery was good, but just there was a lot of bleeding and everything. So um we had that, and that forced me to have chemo and radiation and brachytherapy, trying to just kill this thing, just get rid of it, get rid of it, get rid of it. But then a repeat PET scan was questionable. Like, is this inflammation from the tumor, or is this still something there where that positive margin was? And lo and behold, 6 months later, so now we're in, let's see, January 2023, I grew two tumors, and thank you. I grew two tumors, and um, they were right where I felt them, and I just knew it. So PET scan showed two tumors. My only option this time was the chemo cocktail. The cocktail is comes with Taxol and cisplatin and mostly Keytruda, but it's the Taxol that makes you lose your hair. And I know a lot of women are really, really it's part of your personality. Like I was scared. I didn't want to lose my hair. But I kind of did something different. I took it upon myself, and I wanted to show cancer I am doing something on my own. You are not taking this away from me. So I got dressed up. I got my teal and white. I did my hair, did my makeup, and we had this beautiful session in my backyard where my husband shaved my head, and it was emotional. I cried, but you can see the difference in my appearance from the left to the right. Once that hair was off, I was like, man, I got this. You are going down, cancer. I will continue to fight, and it's not up to you. I'm not going to wait and let you have my hair come out. So we dealt with that with the 5 to 6 months of chemo that was causing sickness. I wasn't able to work. So my husband's the only one working. We are very, very lucky that we have a great support system within our in-laws, my parents and his parents. But stinky little thing that was still the main tumor that was laying right after the hysterectomy in 2022 was still there as of October 2023. So we were like, what do we do? Where do we go from here? Because chemo's not working. Chemo didn't even take it. So again, I was like, all right, well, I guess we have to keep going. So we looked up trials at NIH. We wanted to go to, I was getting great care in Northern Virginia, but I needed like an academic hospital. So we looked at Johns Hopkins. We went to the Cleveland Clinic. They both said I wasn't a candidate for what's called a total pelvic exoneration, which is something I did not want. I never thought I would get there, and I never wanted to have it. But that was going to be the only thing that could possibly save my life. So Johns Hopkins said no. I wasn't a candidate. Cleveland Clinic had said no, but the Mayo Clinic said yes. So next slide, please. So here we went to the Mayo Clinic. We moved from our family from Northern Virginia to Minnesota for 3 months. My amazing parents came to help with my 2.5-year-old daughter. And my husband worked, and I just was in the hospital. It was a lovely 15-hour surgery where they take your I already had my uterus out. They take your uterus out. They take your ovaries. They took my appendix. They take your bladder out. They give you a colostomy. I had tumor going down into my vaginal canal. They sewed up my vagina. Like I'm very open about this, about what my experience has been. Like I was 36 and never able to have sex again with my husband. and they sewed up my anus, which all of us joke about having a Barbie butt, the funny thing. But so this was a huge thing. This was a huge impact on just my way of life. Am still recovering from this. So this was December 2023. Like we saw them in October, and she booked me right for December, and we moved it probably 3 weeks later. It was crazy, but for this surgery, it's about a 6 to 12 month recovery. But I actually had additional issues because my tumor was so deep in my pelvis that they had to scrape the nerves and remove nerves from like my pelvic bone, and also remove some of the muscles in my butt, including like my piriformis and I think some of the smaller glutes. So I still have difficulty with uh, walking and ambulating, like chronic right leg weakness from that. So all the pathology was like beautiful. It was negative. Every single thing was negative. And I was like, please, I'm so tired. Like, please let this be the end. I would love for this. Excuse me. Um, so next slide, please. I forgot where I was going. Okay. So this is kind of like a collage of my life. So if you see the picture of me sitting with my head in the pillows, that's me the day after I woke up from the 15-hour surgery. I was like, all right, we did this. Let's go. Just waiting, waiting, waiting. Teal and white is my life. See how much I wear it. I don't ever take these off. Next PET scan, nervous. Obviously, after the big pelvic excineration, there's a spot. There's a freaking little spot on my sacrum. And we didn't know. We're like, all right, let's just watch it. I was like, okay, can I have a summer with nothing? That's great. We'll watch it. Again, PET scan, a little bit brighter, a little bit bigger. They were thinking about doing something. And this is when my surgeon told me, you are going to die of this disease. And if you would have asked that 31-year-old woman who had stage 1A1 cancer that her doctor was going to tell her that she's going to die from this, I it it's been a journey, honestly. But so I was very, very thankful that the Mayo Clinic doctors looked at it, and it was actually outside of the radiation field that I've already had radiated. So they were able to radiate that spot in um, February of this year. So 2024 was my recovery, but it was not without any, like complications because of the way that they had to reconnect the ureters to my new bladder. I was septic every 4 to 6 weeks. I was in the hospital with sepsis. Had septic shock twice, and I just looking back, I can't believe that. I cannot believe I survived all of that, and I'm thankful that I'm young because that's sepsis kills, and I couldn't do anything about it. I couldn't feel a UTI. I couldn't feel anything until I had a fever, and it was almost like too late. Um, Another thing that I live with kind of is actually you can see underneath where I'm with that big machine, underneath I wear teal and white for dot dot dot. That is the proton machine. It is the coolest thing, honestly. It's like you wait for the beam and you have to sit there and you can't move, and it's really incredible. What a neat and powerful treatment that is. But I was really impressed by that. So um I have been kind of just looking, and this is kind of where I've been, but let's go to one next slide again, please. So, and again, this is more of me now. I am back to part-time working. I do have to take off time and time, like, because I do still travel to the Mayo Clinic um, every 4 months. I just got back yesterday from another surgery to fix that drainage issue for hopefully I won't have to have any infections anymore. I pray it worked. It was a 9-hour surgery. They did great. I love that place. But I got my PET scan and now there's another little spot. And it's like I pray. I just pray. I am a very faithful person and I just give it to God and pray that I can get through because of my family. That little girl and that man right there. I want to live for them. And we still go to Disney World. And yet, see, I'm still sick in the hospital too. And we still get to do stuff. I try as much as I can to do as much as I can, but I'm a different person. And that is very hard for me to understand. That is one of the most difficult roadblocks, things that I fight with myself because I'm just like, no, I am in my head who I can, but physically I am not there. And I don't think I will ever be there. I'm still in physical therapy. I still go to therapy because of the fact that I didn't get to have another child. I am very upset about that. And we were actually pushed back my chemo start to get an egg retrieval, the first chemo round to get an egg retrieval. And we made 6 beautiful embryos and we were going to do surrogacy. And we had to move to Minnesota. So where did all that money go from the surrogacy? To Minnesota to save my life, which is great. And I'm obviously, but it it hurts. But I can't complain too much because I know there's so many women that have had cervical cancer or have it and they just pray for children. Gynecological cancers are just it's not the same. It is just so personal and it's not fair. But that's why we got to push back, get those vaccinations. Honestly, if I didn't get my routine, I'm stage 4A now, but I'm here, we're watching spots. It hasn't spread very far or anything. I'm doing okay, but we need to get rid of it. And this is why I'm so thankful for everything that you guys and the American Cancer Society, everybody has put together to push these vaccinations because I will all die eventually. I don't know if it's going to be this or what, but it could have been earlier for me. And I do believe it's because I was diligent with my health. And that's why no matter who I talk to, I work in weight loss and a little bit in urology. I talk to people about like a woman, did you get your well woman check yet? Did you get your HPV checked? Yeah, you got to go do that. So like that comes up in conversation. So we're it's not anything that isn't outside of my mind. So next slide, please. So just kind of overall overview that it can be lonely with cervical cancer. You feel like you are by yourself, but you're not. There are women there. And that's through Survivor. I found Survivor, which is an amazing support system. Next slide. And just trying to get yourself checked and don't ignore symptoms. Next slide. Survivor just trying to get trying to get advocates to learn about cervical cancer and spread awareness and get rid of it. New slide. And we can do it. New slide. Yep, our story's changed. Sorry. Next slide. And all of these women, just with Survivor, we have lost. And I know that there are probably 5 more that I know that are not even on there yet. So it's it's tough. These are young women, but these are the faces of cervical cancer. Next slide, please. So that's me. Um, Let me know if I can help you in any way. I think Ashley said about my LinkedIn. Here's my Instagram, email, whatever you want to know. I'm happy to talk very openly and answer anything. So I really appreciate you letting me share my story and thank you so much.
Sarah, thank you so much for being so brave and sharing your journey with us. I know you got a lot of love. I was seeing the reactions live. So thank you again for sharing your impactful story. Sarah's going to stay on through the end of the session. So if you have any questions for her, please feel free to add them to the chat and we can definitely get to them here shortly. But I'm now going to turn it over and introduce our next presenter, Dr. Heather Brandt. She's the HPV Cancer Prevention Program Director at St. Jude Children's Hospital and Co-Associate Director for Outreach at the St. Jude Comprehensive Cancer Center. Heather's full bio will be added to the chat, but I'm going to now turn it over to her.
Thank you so much, Ashley. And my goodness, Sarah, thank you for your courage in sharing your story. I know that your story makes a difference every day. And goodness, I think about people like you every day when I do this work. It makes it so incredibly meaningful for me and for our entire team here at St. Jude. So thank you for sharing your story with us so openly. So I'm Heather Brandt, and I direct the HPV program at St. Jude Children's Research Hospital, as you just heard from Ashley. And I am delighted to be here today to talk about our opportunity to prevent HPV cancers with rural communities. Next slide. So, people who live in rural parts of the United States make up a quite significant portion of the population. A lot of times we forget about how many people choose rural life. And these same people often face higher rates of HPV cancers, particularly cervical and oropharyngeal cancers. So, in addition, people who live in rural communities have lower HPV vaccination coverage. All of you joining today are likely quite familiar with these statistics and much of the data that I'll be sharing shortly. I think it's always really important to think about survivors like Sarah, because every single one of these statistics that I share with you today has a person behind that number. And that's what really drives our focus on addressing and preventing these HPV cancers. Next slide. So at St. Jude Children's Research Hospital, we prioritized identifying and focusing our efforts on populations that are under-vaccinated. Who is missing out on HPV vaccination? And certainly, as I just shared, people living in rural communities often miss out on HPV vaccination. So starting in January of 2023, we convened a think tank of subject matter experts to help us identify 6 priority actions. So, in other words, what can we do, what should we do, and what must we do to increase HPV vaccination coverage among everyone, especially all children, for on-time vaccination in rural communities. And so those 6 priority actions are shown here. So 2 years have passed since we released these in November of 2023, and we know an awful lot has changed since November of 2023, particularly the climate around public health in general and the climate around HPV vaccination and vaccinations overall. So there are also increasing threats to people living in rural communities by eroding the public health and medical infrastructure that exists, making it further alienating to access care and be able to obtain preventive services. So this is one of the reasons why we now, next slide, have really started to take on this revisiting these 6 priority actions. So we've been meeting over the last few months with subject matter experts, and we will be releasing updated priority actions. So again, what can we do, what should we do, and what must we do in order to address the declines in HPV vaccination that are being observed, the deficits that are observed in order to prevent HPV cancers, because People choose rural life. They don't choose rural cancers. And there are things that we can together do about this. So next slide, we hope you'll join us on November 20th, which is National Rural Health Day. One of my team members can possibly throw the link in the chat if you haven't already registered for this celebration. We believe rural communities have far more strengths than they do deficits. And so this is one of the underlying principles of our focus on rural HPV cancer prevention. So as an under-vaccinated population, we know that this is a group that we want to reach, and we also understand about several other factors related to rural communities that inform our efforts. Let's go to the next slide. So I mentioned that each of these data, statistics, numbers all connect back to a person and a family. And this experience isn't just merely black and white or just a number on a paper or in a report. These rural HPV data really tell us a story. Next slide. And the TLDR version of this story I've already touched on today. And in simplest terms, this is really the reason for our focus at St. Jude and with many national partners on rural HPV vaccination, because people who live in rural areas in our country experience higher HPV cancers and have lower HPV vaccination coverage as compared to people who live in urban areas. We also know that rural doesn't mean one size fits all. Rural communities are not monoliths. They are heterogeneous and they reflect significant diversity of people who make up our country and rural communities. So people who live in rural communities also don't check one box at a time. They may simultaneously experience these advantages and disadvantages. And so our approaches within our program and overall to rural HPV vaccination really can't be singular, and they have to account for and embrace these differences. So I also acknowledge the many strengths that exist in rural communities, building on what does exist rather than dwelling on what may not exist. And that's why it's so important to focus on HPV cancer prevention and why all of you are here today. Next slide. So we, as one of our priorities, have undertaken a very detailed look at data. What data are available to help us understand how our efforts can be most targeted and most directed to have the most impact? What does that look like? And so here is what we knew about HPV cancers in the rural US in a paper published by Dr. Whitney Zond a few years ago, where she and colleagues took a look at HPV associated cancers in the US. And so at that time, we saw rural females had significantly higher rates of HPV cancers compared to urban peers. Rural males had higher rates of penile cancer, and rural females and males experienced greater rate increases. So the numbers and the data kept going up, and smaller declines if there were any advantages or if there had been any progress made for nearly every single cancer site. Next slide. And so when we started digging into data, working with Dr. Jason Semprini, who I know has presented previously as part of this learning community series, we started looking back at data. And I have to tell you, I was very surprised by how the data played out. 20 years ago, HPV cancers in rural and urban settings were almost equal just 20 years ago. And this is all HPV associated cancers combined, shown here in this chart. But you can see over time how the gap has widened. And that really can be driven by decreased availability of preventive services. But just 20 years ago, it was the same. And so what is happening in rural areas that allow us to act and really reverse this trend line that we've been seeing and see the trend line go down as well? Next slide. So in a letter that Dr. Semprini published, we also saw similar rising trends in incidence and mortality overall, including some really unreal accelerations coming out of the COVID-19 pandemic and the lockdown phase of the pandemic. And so, of course, during the pandemic, the early part of the pandemic, we saw real declines in cancers being diagnosed. And that was because people were not going in for routine preventive and early detection services. And so we expected to see a bump as we were coming out of that early period. And we did. We saw an increase. For urban areas, that increase was 5 to 6%, but for rural areas, it was 18%. For a rate like this to increase by that level, this is a huge indicator of challenges facing rural communities when it comes to HPV cancer prevention. Next slide. So putting all of this together, it's what do we know now? So looking back at Dr. Zahn's paper, looking at this investment in data analysis that we made in partnership with Dr. Semprini and other data experts, we find that rural females continue to have these significantly higher rates. Rural males continue to have higher rates of oropharyngeal cancer, and they're also experiencing greater rate increases or smaller rate decreases. And one of the main findings that Dr. Semprini found in one of his papers is the puzzling part is it doesn't seem to have a consistent pattern. And so he has been digging into the data even further to try to identify patterns, because patterns are what ultimately can inform our actions and result in our actions leading to impact. Next slide. So now I want to transition to HPV vaccination, and I'm going to start just with a quick picture overall. I'm sure y'all have seen this chart before. So HPV vaccination lags other routinely recommended vaccines, namely vaccines for whooping cough and meningitis, recommended at about the same age range. Next slide. And here's what it looks like when we take a gander at the map of the United States. And these are the NIS teen data for ages 13 to 17. And you're probably very familiar with this data source, but when this ages 13 to 17, someone may have been vaccinated and between ages 9 and 12, but the survey is of 13 to 17-year-olds to find out if they have been vaccinated during the time of the study. And you see here that with one or more doses, which is generally characterized as initiation, you can see some patterns here. You can see that there are areas of the US where there are lower coverage, especially look out at the Mountain West, which is rural and frontier, and also through the middle of the US and into the Southeast. Next slide. Up to date implies series completion, meaning that someone has had 2 or 3 doses as recommended for them. And you can see these similar patterns. And overall, you note that initiation is much higher than it is for up to date. And also NIS teen data are really great for examining trends over time, but at a single point in time, there are many other data sources, including within your clinic, practice, healthcare system, state IIS, looking at claims data or other resources. There are many sources of HPV vaccination data that should be examined when really determining what your estimated rate and coverage is for the area that you're serving. Next slide. So one of the concerns that's persisted over time, and this is really concerning when we think about that graph I showed earlier or chart I showed earlier, where 20 years ago, HPV cancer incidence for rural and urban communities were nearly equivalent. Because what does lower vaccination in rural communities mean today? It means, unfortunately, higher rates of of people in rural areas getting HPV cancer in the future. And so HPV vaccination has pretty steadily hovered around 10 to 12% lower in rural communities compared to urban communities. Next slide. And so here's a look at how important a healthcare provider recommendation is to HPV vaccination. So all the way over on the left, this is for anyone who received a healthcare provider recommendation for HPV vaccination. And you can see that those rates are fairly high. 2/3 of people are getting a recommendation from a healthcare provider for HPV vaccination. And then over to the right of the line, you see 1 or more doses of HPV vaccine with a recommendation compared to 1 or more doses of HPV vaccine without a recommendation. In rural communities, which is the darkest teal color, it's a 20% difference in a rural community if a provider makes a strong recommendation or doesn't. And if you move over 2 more, you can see HPV up to date with a recommendation and without a recommendation. And it's more than 20 percentage points difference there too. So that's how important it is to have a strong healthcare provider recommendation for HPV vaccination. Next slide. And so here's what those differences look like between the urban area and the urban area. And you can see that there are differences across here. Next slide. And so what this tells us is that children who are living in mostly rural areas were less likely to receive a provider recommendation for HPV vaccination compared to those in urban areas. We can do something about that. We can help provide capacity building and training opportunities for healthcare providers and professionals who are working in rural communities and serving these communities from cradle to grave, providing extraordinarily high quality care by providing simple steps for how a strong recommendation can really address some of these gaps. Next slide. Also, when we look at children who received a recommendation from a provider, the difference still persisted between urban areas and rural areas as well. So again, I view this as a really ideal opportunity for us to be able to act and lead about change to address some of those gaps that we experience. Next slide. So a few things. So as we look at these data, a few things emerge, including cultivating pro-HPV vaccination environments within healthcare settings. And I use healthcare settings to encompass any range of setting where HPV vaccination is recommended and or administered. Thinking about how we can build HPV vaccination confidence, confront misinformation. We've seen here in these latest NIST data the importance of offering training and opportunities for healthcare providers and professionals who are serving rural communities to learn how to make a strong recommendation. And in many cases in rural areas, we have to think about expanding access points and also addressing policy barriers, something that I didn't have a chance to get into detail about today, but we've also been studying as part of our priority actions, is we've identified that healthcare providers who are serving rural communities are reimbursed for HPV vaccination at the lowest possible rate. And so that seems like a difference or discrepancy that should be addressed through regulatory change so that a healthcare provider, regardless of where your feet are planted, if you are administering HPV vaccination, that you're being reimbursed at the exact same rate. So these data certainly all offer us these and more insights. Next slide. So now let's talk about why it's so important to start HPV vaccination at age 9. So we've seen these data. These data tell us a story about the opportunities that exist for us to make investments in working with people who are living and serving rural communities to help enhance the capacity and increase the availability of easy to use, easy to access resources that will help increase HPV vaccination and prevent HPV cancers down the road. Next slide. So the traditional recommendations based on today's presentation from the Advisory Committee on Immunization Practices and the Centers for Disease Control and Prevention, or CDC, on-time HPV vaccination is among children who are aged 9 to 12. Completion of a 2-dose series by the 13th birthday is considered on time. And then after that, we have late with still 2 doses, a late extra dose, and consult. And one thing I wanted to just quickly mention, the age of HPV vaccination is really determined based on a couple of things. First, immunogenicity, in that people who are younger have a higher immunogenic response, meaning their body's response to the vaccine produces sufficient antibodies to protect them at a level that someone who's older, their body may not produce the same level or degree of antibodies. And second, related to behavior. This is a preventive vaccine. We want to make sure that people get this vaccine before they would be exposed to HPV through intimate contact, whether by choice or force. Next slide. So I really love this image from the roundtable that tells about how important it is to start at age 9 and all of the many benefits. This emerged as an important strategy a few years ago. The American Cancer Society, American Academy of Pediatrics, and more really emphasized the importance of starting at age 9. And there are several noted benefits that have been documented in many research studies. And we've been working with the ACS National HPV Vaccination Roundtable and our partners at ACS as well to be able to promote this. Initiating the series, more adolescents start and finish the series on time by their 13th birthday, leaves more time for completion by age 13, stronger immune response to HPV vaccine at this age, increased likelihood of vaccination and protection before first exposure, fewer questions about sex at age 9 and 10, fewer requests for only vaccines that are required for school, fewer shots per visit, highly acceptable to systems, providers, and parents. So these are all of the reasons, next slide, why HPV vaccination has been incredibly successful. And so looking at why it matters so much is because on-time HPV vaccination coverage really is where we see the most benefit downstream in preventing precancers of the cervix and actual cases of cervical cancer. And those many benefits that I mentioned are included here. Next slide. So I want to particularly emphasize those 2 points about vaccination recommendations and why age 9 fits in with that so well. At younger ages, children are much less likely to have been exposed to HPV, so the preventive vaccine can protect them at the maximum possible level. And we know that their body's response, their immune response, the immunogenicity of their immune system reacting when the vaccine is introduced is much higher when HPV vaccination is given on time. Next slide. And so maybe you're like, I'm still not convinced about age 9. Well, it works better. I mean, that should be the main lead here, is that it works better. And this study that was done actually before 2013, it's using years before data. It's considered the gold standard in showing the serious reductions in precancers of the cervix as a result of being vaccinated before age 14 or on time by age 13. Next slide. So starting at age 9 really works well in rural communities in particular, because it provides more time to complete the series. It allows for this focus on cancer prevention before any potential exposure. And this is really good news in rural areas where potential limitations on access to healthcare and lower vaccination rates can make it harder to complete the series by the traditional age. And so by starting at age 9, healthcare settings can really achieve these higher completion rates and prevent more HPV cancers down the road. Next slide. So some of you know that I grew up in rural Iowa. I was just there a couple of weeks ago, and my rural roots really run deep. My dad took this picture last year during harvest. He was driving the grain cart. One of my uncles is driving the combine, which is the wrong color. And if you grew up farming, you know the debate. I'm Team John Deere green, but my uncles are not. I know the many strengths of rural communities. I also know the challenges that face them and how HPV vaccination has been such a challenge in these communities. I also know at the same time that there's something that we can do about this. There's something about something that we can undertake to really prevent these cancers in rural communities. Next slide. So right now, we can't do our work without acknowledging the current environment and how it threatens people living in rural communities, threatens their health. We have to work to preserve Medicaid expansion in states where it's already been expanded. We have to ensure the Vaccines for Children's program is fully funded. We have to make sure healthcare providers and professionals serving rural communities have all of the resources they need. And we also must provide access to knowledge and actual doses of vaccine to be able to act on the power of knowing, because HPV vaccination is cancer prevention. Next slide. So thank you, and I look forward to your questions. And if you don't know what a grain cart looks like, because I realize some people don't, here's what it was. This is what my dad was driving and stepped out of to take the photo. So I do look forward to our discussion, and again, just want to express my gratitude to Sarah for sharing her story with us today as well. Thank you.
Perfect. Thank you, Heather. That was so wonderful and so many great ideas that you shared throughout the presentation and talking about the data, as well as opportunity for HPV vaccination at 9. So I didn't see any questions into the chat, but I've got a couple that I'd love to talk to both you and Sarah about. So, Heather, you just shared that you grew up in a rural community. So I guess thinking about how do you approach conversations around HPV vaccination, especially when you emphasize the importance of starting at age 9?
It's a great question, and I'm really fortunate in that I have such a large family that still lives in Iowa. I hear all sides of the discussions, and so I think it starts at meeting people where they are. And so if someone, most my family knows that this is what I study, and so I get asked questions all the time. And so I always say, well, tell me what's your main concern. Tell me, where did you hear that? Well, what are you worried about? Just taking it on and to meet them and find out where they are. So then I can provide them with information to consider where to look for additional information. I don't think that not choosing HPV vaccination is an information issue only. I think there are many factors that weigh in on whether or not someone is vaccinated. But I think it starts with meeting people where they are, listening and understanding their concerns so that we can try to address them. And if it comes to age 9, I'll be honest, my experience with age 9 in rural communities, it's really been people don't know that you can start at age 9. That is a surprise to them. So that may be an example of how information can empower people to choose to start at age 9 to protect their kids.
Perfect. Sarah, as a survivor and also as a healthcare provider, I guess, what are your thoughts? Like, how would you approach the conversation around HPV vaccination and really emphasizing age 9?
Um, it's hard. I don't really interact with many like younger, you always do at adult medicine, but if I like now, since I always talk to women, I'm like, you need to get yourself checked. You need to do this. Like in any conversation, you can, if you see a child with a or if you see a patient with a child, or if you know that they have three kids at home, just kind of start the conversation and just all you have to do, I feel like, is just communicate. Just start communicating, tell them about things. Just, you don't have to be like, okay, we're doing the vaccination right now. No, it just give them the opportunity to learn about what is out there and what is available to help save their child and try to get rid of these awful cancers in the future. So again, just communication and just being open to discuss it. I actually had during one of our survivor schools, we try to do different things. Like I'm very open with my stories, as you can tell. But some of our other survivor sisters are not. So she's like, how can I try to like spread the word? She got made buttons that said, ask me about the HPV vaccine. And she has had people in the grocery store line be like, what is that? Or like waiting in line to use the bathroom. So like she puts it on her purse or backpack, and that actually gets people talking about it. So there's a lot of different ways, and it's always, I think, just with communication.
Perfect. Thank you, Sarah. I'm gonna ask this question to Heather. Seema asked, is there any data about uptake of the HPV vaccine in different ethnic groups, and are there certain groups that are more hesitant? So I don't know if you have anything you can share, Heather.
Sure. So there are data that examine HPV vaccination by race and ethnicity, and also by insurance status and a number of other characteristics. And some members of our St. Jude team will put links to some fact sheets that we have available for some of these groups that will provide you with those data. There also are mixed data, and in particular, we're just wrapping up Hispanic Heritage Month, and data among people who are Hispanic and Latino tell us that they experience some of the highest rates of cervical cancer as an HPV cancer downstream. But when we look at vaccination data, we see that many children who are Hispanic, according to NIS teen data, have the highest rates of HPV vaccination coverage. So this brings us good news for thinking about how we address downstream the challenges experienced with cervical cancer. With that said, there are certainly data sets in California, Texas, Florida, and through other health systems that tell us differently, that they show us that children who are Hispanic or Latino have lower HPV vaccination rates. So again, back to my comment about taking a look at multiple data sources, I think is very important. In terms of hesitancy, hesitancy seems to be so widespread that hesitancy exists among all racial and ethnic groups, all different descriptive characteristics. It's very hard to predict. We do see that prior to the COVID-19 pandemic, children who were publicly insured were more likely to be vaccinated against HPV than were their privately insured counterparts. Now that has changed somewhat during the during the pandemic. But this is something that we've always wondered about. And is it a product of a child who's publicly insured is going to get all recommended services because they're unsure when they'll see them or when they'll be able to access the system again? So these are all things to consider when we're taking in these data, but certainly some of those definitely exist.
Perfect. Well, thank you both for joining our Q&A and for joining and sharing, Sarah, your story with us, and Dr. Brandt, all of the great data and information you shared on rural communities and HPV vaccines. I really appreciate it. In the interest of time, I'm just going to go ahead and wrap up, and we will get you guys on your way. So if you want to go to the next slide, Hannah. We love our polls around here. So we would love for you to share with us anything new you learned about HPV vaccines at age 9. Additionally, we are going to be asking you if you'd be interested in attending future sessions to talk about other rural cancer-related topics. And if so, if you could rank those for us, just to give us a better idea. We're going to keep the poll open, and we're going to keep going through the slides. So feel free to go ahead and take some time to answer the poll. All of the resources I share here at the end will be included in our wrap-up email. So as we mentioned in the past, this is our landing page we've created just for all of you who participate in our rural HPV vaccination learning community. There's a link in the chat, but it's a great place to access all of our resources, recordings, and whatnot. Next slide. And with that, we've also created a resource roundup. It's a very comprehensive, and we actually have an entire section built around HPV vaccination at age 9. And I'm going to continue to update it with new resources. If you in particular have a resource that you would want to share, just go ahead and reach out to me directly, or you can add it into the chat. I know we did that last time when we were talking about trusted messengers, and we added all of those great resources into this document, but we are always looking to add more. Next slide. So we have several webinars coming up that we want to invite you to. So St. Jude is going to have one just tomorrow to talk about close-knit, far-reaching, harnessing the strengths of rural communities. So Kayla's going to add a link into the chat so you can register for that, but it is tomorrow, so you want to do that quickly. Next slide. I also know community health workers are a valued trusted messenger when it comes to rural communities, and we have a new webinar series specifically to support community health workers. The first session will be on October 21st, and it'll cover tobacco cessation, lung health, and motivational interviewing. Kayla's going to add a link into the chat as well. I would not be remiss if I didn't mention that October is Breast Cancer Awareness Month, and actually Kayla is going to be hosting a webinar next week on best practices for improving breast cancer screening rates. So this series will highlight the current state of breast cancer, talk through screening guidelines, and there's actually going to be some best practices shared as well. So if you'd like to join, once again, there will be a link included into the chat, and I'll also make sure it's in our email we send after this. Next slide. Dr. Brandt shared that St. Jude is going to be hosting a great webinar on National Rural Health Day. So that's going to be happening November 20th. If you'd like to join, please scan the QR code, or there'll be a link in the chat as well. And as always, we like to end the session with a call to action. So when it comes to engagement and education, recommend the HPV vaccine starting at age 9 to all parents, caregivers, and community members. Walk the talk. If you are a parent to a child that's 9 plus, start your child's HPV vaccination series. When it comes to interventions, there's lots of opportunity. You can change your organizational policy to adopt HPV vaccine starting at 9. You can train staff about the policy chain and emphasize why 9 is so important. Update your EMR system to alert due at now and trigger automatic vaccine ordering when it comes to age 9. Utilize patient education that really emphasizes HPV vaccine starts at 9, and you can send client reminders about the HPV vaccine, including birthday campaigns. Community outreach, lots of opportunity as well. You could do social media messaging. We have a great social media toolkit. You can work with a community partner to host an info session or a parent night to discuss HPV vaccination and cancer prevention, really emphasizing age 9. Or you can share educational materials with local schools or youth programs. And then there's opportunity within advocacy and action. You can support policies that expand access to early HPV vaccination in rural communities, or join or start a campaign to raise awareness about the importance of vaccinating at age 9. If you want to go to the next slide, I want to thank you for joining today's session, and we look forward to seeing you on November 12th for our next session. So thank you.